Well, hello. Today we're going to talk about wound assessment. And we're going to kind of have to go back to the basics and talk about the layers of the skin in order to understand how a wound's going to heal. You have 5 layers to your epidermis, but the only 2 that I'm going to really stress on today is the stratum corneum, which is the uppermost layer, and it's mostly just dead cells, keratinized cells. And then I'm going to talk to you about the basal layer, and that's the dermatitivum layer. That's where cells reproduce. That's where you get the new growth from. So you have to make sure that that layer is good. The other layer that you have to worry about is the layer that's between the epidermis and the dermis, and that's called the epidermal junction, or the basement membrane layer. And that's another area where there's growth, where there's tissue formation. So you have to make sure that the tissue is healthy all the way down through if you're going to have good wound healing. Whenever you're looking to see how a wound is going to heal, there's some really important things to know. How big is your wound? Where is it located at? How did it happen? All those things are going to come into play regarding how the wound heals. What layers are involved? Is it just the epidermis? Is it just kind of a road rash kind of an abrasion thing and it's just the epidermis? Is it borne down into the dermis? Does it go through the dermis? Does it go into the bone or to the muscle? How deep is it? Because that's going to play a big role in how that wound is going to heal. If it's just a partial thickness wound, if it's not down past that dermativum layer, then it's going to heal by regeneration, and you're not really going to have a big scar. But if it goes down below that, you are going to have a scar because it has to heal differently. There are 3 types of healing. There is primary intention, and that's when you have a surgical wound and the doctor just sutures it up or he staples it up. And we're going to learn how to assess those wounds and how to take out sutures and staples. The next type is a secondary intention. With secondary intention, the wound's just left open. It's not that big. It's, like nothing's going to fall out from it. So you just let it kind of heal from the bottom up. Takes a little bit longer, and that's when you wind up with a scar. Third intention is when the doctor opens up a wound. You come in and you've got something and he works on it, he fixes on it, but you've got so much swelling or so much infection there that he really can't close it up right now. He has to leave it alone so that it'll decrease swelling, or he puts a drain or something in there to get rid of some infection, and then whenever it's a little better, then he goes back and he closes it. So it's kind of delayed by like 3 to 5 days, just to kind of let the wound heal a little bit before he does anything with it. All wounds heal in 3 stages. The first stage is inflammation, and that's where all the white blood cells come, all the red blood cells come. Usually that's when you get a little bit of swelling because you got all that fluid coming. But the red blood cells come because they have to bring a little bit of oxygen to the area, because healing is work and it takes oxygen. And the white blood cells come to help fight off any infection that's going to be there. And then you have the swelling. The second stage is proliferation, and that's when you have the healing. That's when the new growth begins. You're building new cells. You're starting to fill in that gap a little bit. And then the scar formation is the third step. It's restorative. And there's a great video in chapter 38 that you need to watch, because it actually kind of shows you how that works out and how that walks out, how that happens. So please make sure that you read your chapter, watch your videos, because you get a lot more from that from just me talking about it. It's better to be able to see it, and I can't show it to you as well as that video can. So watch that video too, please. When you look at a wound, wounds can be red, yellow, or black. Red is good, especially if it's shiny red, because that shiny red, moist tissue is, and especially in the picture I have in this side, you'll see some little tissue buds, some little granulation buds. It looks kind of bumpy, and that's great because you're building new tissue. This one is actually in the proliferation stage. I want you to look at the bottom of the wound around the edges, though. You notice that it's black? Well, that can mean one or 2 things. Either you've got a little eschar going there. Eschar is a problem. Eschar is the black hard tissue. It's a problem because you don't know what's underneath it. You really can't stage that, because you may pick it up and find that now you've got another 2 inches underneath that you didn't know about. Or you can take it off and it's really nothing more. It was just a little bit black on the top of that, and it's okay. It could be eschar, or it could be tunneling. So on a wound like this, I would suggest that you take a Q-tip, a sterile Q-tip, and just kind of touch and see what happens. If you touch that and it separates down easily from the tissue up above it, you've got tunneling. That means that you've got a wound that's kind of gone underneath the layers that you already see. It's deeper than you think it is because it's tunneling up underneath it. It's just like, you know, tunneling a mountain. It's just going on through. So you have to find out if it's tunneling, where it's going to, how deep it's going, and you're going to do that with a sterile Q-tip. Just be gentle, okay, because you can get to areas where it really hurts. The other thing that you can sometimes see in a wound, and you really don't see it in the wound I've got in here, but sometimes you get this yellow slough or tan slough. And what it looks like is just stringy, sticky, gooey yuck. That's also not healthy. That has to come off, okay? That wound is not going to heal as long as you've got eschar or you've got slough. So you're going to have to get that out of there. And there's a few ways that you can do that. We're going to talk about those in a minute, but we're not there yet. Hang on, there's more to come. So in order to get that off and to just get the bacteria in general off, you're going to need to cleanse the wound. Well, you're not going to take a wash rag and scrub in there, right? So what are you going to do? Well, you're going to take and you're going to irrigate it. The best way to do it is to get a 35 milliliter syringe, kind of big Hawkins syringe, and put a 19 gauge angiocath on it. So what's an angiocath? Well, an angiocath is the plastic part that goes over the needle whenever they put an IV in. They put this needle in, and then they leave the angiocath and they take the needle out. So it's plastic, it's real soft, it's real wiggly. The reason why you don't want to use a 19 gauge needle is, you know, if you sneeze or if the patient moves, you really don't want to be sticking that needle into the wound, right? So the angiocath allows you to go from an area of a larger bore to smaller bores, so you get pressure as it's coming out that needle. You're pushing on something big, it's coming out something small, you're going to have some pressure to it. So that pressure is what cleans it out. And you want 4 to 15 psi, pressure per square inch. And that'll just wipe off that. It'll clean out that slough, it'll clean out that, especially the bacteria, any debris that's wanting to grow in there. And it'll also soften up that slough and the eschar a little bit so that you can get it out. When you clean, though, you want to go from where it's least infected to where it's most infected. So look at your wound, okay? If it's got like a really cruddy area, do that last. In general, you want to clean, what do you think? Give you a second. Yeah, top to bottom, because gravity works, right? So if they're standing up, all that exudate is going down. So where is it going to have a better chance to colonize and really grow? On the distal part of the wound. Remember, distal means further from the heart, proximal means closer to the heart. So the distal area is where it's more likely to be kind of, really nasty. So try to go from proximal to distal when you're cleaning so that you're not spraying the bacteria up in to the area that is less infected. You're going to want to use a sterile solution with that, especially if it's a surgical wound. If it's a chronic wound, you may get away with something that's clean but not necessarily sterile. Just be careful though, because you don't want to infect those chronic wounds either, because they can go bad as well, right? Just because it's been there for a while doesn't mean you don't have to worry about it. You don't want to get them infected because then they get worse instead of better. Safety guidelines. Okay, we're talking about wound care. What do safety guidelines have? What does a patient's age have to do with a wound? Why do we care what their nutritional status is? What about, what's with oxygen? Why are we caring about these safety issues? Well, because as a person ages, their immune response decreases a lot of times. It's harder for them to heal. If they're getting chemotherapy, it suppresses the bone marrow. So they're not able to produce the white blood cells that they need to fight the infection. If they don't have good nutrition, they're not going to be able to build up healthy tissue. They're not going to be able to build up their immune system. They're going to be more prone to infection and slower wound healing. So you have to think about all these things. What's obesity got to do with it? Well, usually whenever you're obese, your vascular system is trying to feed a lot more. You may not get as much oxygen to your wound that you need to get. If they're a smoker, they're going to have a decreased hemoglobin count, and you need hemoglobin to carry oxygen, right? We're going to get into that a little bit more too. I'm kind of jumping ahead of myself just a little bit. But if their hematocrit's below 33, if their hemoglobin is below 10, if they're a smoker, if they have heart problems, if they're not getting blood flow to the area, they're not doing a good job of getting the white blood cells there, getting the oxygen there, and taking away any of the toxins that are being produced so that they can be gotten rid of. So it's going to take a longer time for that wound to heal, and you're going to have to watch it a lot closer. Know about the types of medications prescribed. Why does that matter? Well, if you're not very far through pharmacology, if you've not started taking yet, you may not know. So let me tell you. If a patient is on steroids, that decreases their immune response, and that makes them more prone to having an infection. If they're on chemotherapy, as I said, it decreases their white blood cell count. There are a lot of medications that mess with, that decrease blood flow. Smoking really is bad about decreasing blood flow. So you have to know what they're on so that you can know how that's going to affect their wound healing. You need to know if they've got diabetes, because diabetes is terrible about having torn up blood vessels. Their vascular system, especially to their extremities, is terrible. Sugar is a huge molecule. Dextrose is a huge molecule. So as it goes through, it just like rips up everything. So they do not have as good a blood flow. It's going to take them longer to heal. They don't feel as well. It interrupts their ability to sense things. So they may have a wound and not even realize it. My aunt broke her foot, didn't realize that she'd broken her foot, and the bones went kind of settled down to the bottom and worked their way out through the bottom of her foot. She had a hole in her foot like this big, didn't even know. So they have to really check their feet every day and make sure what's going on. But it kind of came out that way because it went from the inside to out. So they can have some really terrible wounds. If they have venous insufficiency, if they're not getting good blood flow, that'll create a wound. If they have arterial bad blood flow, that'll create a wound. So you have to know why that wound's there, what happened, in order to be able to appropriately address it and understand the causative factors behind it so you can do curative things, right? Once skin is wounded, it's never as good as with the original, right? God made us great. He made us to where we work really, really well. He put things together just the way they need to be. So whenever we heal, it's not as good as the original. It'll still work, but it's not as good. It doesn't provide all the same protection. It's not as strong as original skin.